Okay, here we go with part 2 of chapter 20, which is discussing the eyes, ears, nose, and throat diseases that can kind of affect us. We left off kind of talking about the structures of the nose, so we're going to pick up this one with talking about assessment and management of some specific nasal conditions or nose conditions. All right, so epistaxis is a very common thing that we see in the field and that we can get a call for. Ironically enough, the most common cause is some form of digital trauma. Some other causes might also include dryness or hypertension. It can also be medication related if they're on anticoagulant type of medications too, but most commonly it's caused by digital trauma. So there's two different types. The two types are anterior, which is the most common type, and this type usually resolves itself on its own pretty quickly. The other type, however, the posterior type, is usually more severe, and the main problem with it is the blood has a tendency to drain towards the back of the patient's throat and into the stomach, and may cause nausea and even vomiting if the bleeding is severe enough and lasts for long enough. So when we begin to manage these patients, the first thing we need to do is try to estimate how much blood the patient has lost. If it's bleeding externally, that's more ideal. If it's a posterior bleed, it's going to be more difficult, and you may never be able to have a really good idea of how much blood loss there is. For non-traumatic patients, have them lean forward, or have them sit up and lean forward. Pinch their nostrils together firmly for about 20 minutes. Be sure to tell the patient not to sniff or blow their nose during this time, because they'll blow the clot right out, and maybe we can get that to clot off and prevent it from bleeding any further. Foreign bodies are commonly found in kids. For some reason, they are fascinated by sticking things up their nose, but if it gets stuck, it can cause some serious tissue damage. May result in some inflammation or swelling. It can also lead to ulcers in the tissue and nosebleeds from the irritation. And in some cases, it may even cause a sinus infection because of the blockage that it creates. Oftentimes when little ones put things in their nose, they may not say anything about it until it starts to become a more serious problem for them, and even then they may not. We may not always know that there's something up there. If there is something in the nose, the first thing we need to do is determine if it's a life-threatening emergency or not. A big red flag is going to be a nasty or persistent bad-smelling discharge from the nose, which usually means there's something stuck up there that's not allowing things to drain. So we don't want to try to force it out or to pull it out. Let it drain naturally. And we're going to have to transport them to get that out. Keep the patient comfortable and upright when possible. This helps keep the object from maybe going deeper back into the sinuses. It also reduces the risk of any kind of aspiration. So if we can keep things draining out the exterior rather than running down the back of the throat, that's always better. If the patient's in significant pain or they're really anxious, we may consider pain control or sedation. If it's within your scope and your protocol is going to allow that. If not, you're going to have to reach out to medical control to see if they will allow you to do something along those lines. Rhinus is an inflammation of the nasal cavity. So really think of this as just that stuffy, runny, irritated nose that we all get. Usually in the springtime, sometimes in the fall. Usually it's allergy related. A lot of other things can cause this beyond allergies. Sometimes it can be medications, changes in weather from hot or cold, or even infections. Both viral and bacterial infections can cause this stuffy nose feeling. Some other culprits can be, like I mentioned, there are certain medications that cause stuffy nose. And of course, as we mentioned, foreign objects being stuck in the nose. Smoke or strong smells can cause it too. And even some hormonal changes, during pregnancy can cause stuffy nose as well. When assessing stuffy nose, make sure you may see and hear sneezing. They may have their nose may be itchy or runny. They may have watery eyes. They may even have that postnasal drip of things kind of running down the back of their throat. And coughing may be pretty common, especially at night when they start to lay down. What's really helpful for them usually is to keep them upright in that Fowler's position. This helps with drainage and makes breathing a whole lot easier. Transport, kind of depends on the need. If the symptoms are severe enough or there's a concern for something more serious, then we're going to have to transport. But typically, a stuffy nose is not something that is the primary reason why they called us, but it may be, another symptom or a sign that they're having along with whatever else is going on with them and is why they called. Sinusitis is an inflammation of the sinuses, often caused by a blockage of a blocked sinus drainage. What happens is it begins to build up pressure, and the patient will start to feel a lot of pain around their face and their cheekbones, typically maybe behind the eyes. They may have a sore throat and a stuffy nose. They may even have a toothache or have toothaches and headaches to go along with this. It's pretty common. Fever and chills, muscle aches kind of play a role in here too. According to the CDC, about 28.9 million adults in the U.S. deal with this every year, so this is not uncommon. So it's a pretty common thing to happen. Not real likely to get an ambulance call for it, but again, it may be part of a bigger set of signs and symptoms that the patient has that may be an indication of something going on. Younger kids and older adults are typically at higher risk of sinusitis than middle-aged adults. It can be chronic, acute, or even reoccurrent. Of course, in the field, we're going to focus on managing any respiratory issues and getting the patient to the hospital if needed, and not delaying that treatment. The goal is going to be to reduce inflammation and help the sinuses drain all that's getting trapped up in them. Mild or moderate symptoms, they may try saline rinses or even decongestants. And if the symptoms persist beyond 7 to 10 days, they may actually start them on some antibiotics. This is typically not something that we're able to do in the field, but for those of you paramedics that might wind up working in the emergency room, you may be a part of that treatment regimen. All right, so the throat. I believe this is the last part that we're going to talk about, when it comes to the ENT stuff. So throat issues can come from acute inflammation, infections, chronic conditions, or even abnormal growths. Some common disorders include vocal cord polyps and nodules, contact ulcers, vocal cord paralysis, laryngeal palinomas, and cancers. Throat infections are especially common in children. Swallowing problems can make the throat issues seem much worse. And of course, remember, we're talking about cranial nerves 5, 6, 9, and 12 are involved in that swallowing process. So some neurological issues like stroke or trauma can cause difficulty with swallowing as well. Aspiration pneumonia, of course, is a big thing that we worry about with these patients because it is a life-threatening condition if they wind up inhaling or getting food or fluid going into the lungs. All right, so there's a valve at the bottom of the esophagus that keeps the stomach acid from flowing back up the throat. When you have esophageal reflux, that valve doesn't work quite the way that it's supposed to. It either doesn't close fully or open as far as it should. And this can cause a burning feeling or sensation in your chest that we commonly refer to as heartburn. It can also cause some indigestion where those stomach contents are kind of coming back up. And it can cause a change in your voice tone because of how those acids and things kind of affect your vocal cords. If it keeps happening, it can lead to some precancerous conditions of the esophagus, so it definitely needs to be treated and taken care of. The adult mouth contains 32 teeth that are actually meant to last us a lifetime. And of course, each tooth consists of several layers that are embedded in bone and gum tissue. And they're critical for us being able to actually ingest and digest our food. As mentioned in the previous chapter, the head and mouth are heavily innervated. The hypoglossal and glossopharyngeal and trigeminal and facial nerves are responsible for the mouth and everything in it, for all those movements of the mouth. So it takes a coordinated effort to actually be able to manipulate the food that we take into our mouth to where that we can swallow it and begin the process of digestion. All those things have to work in harmony. Of course, the neck consists of the anterior and posterior portions. The anterior part of the neck includes the thyroid cartilage, the trachea, and of course all these muscles and nerves, along with a major set of blood vessels that flows through there. The major blood vessels in this area are the internal and external carotid arteries. And of course, we have the vertebral arteries that run alongside the cervical column in the back or the posterior part of the neck. Remember that this image really just kind of shows us of the vascularity of the neck and how little protection there is from injury. This vascularity actually extends into the interior and exterior portions of the skull. So inside the head and outside the head, remember the scalp and all that of the head, which we'll talk about in a later chapter, is very, very vascular. So these areas, it doesn't take a deep cut to cause injury or to cause a lot of bleeding. So there's a lot of vascularity there. And when we begin to assess patients, especially patients with swallowing abnormalities or copious amounts of mucus production, remember we should place them in a position that allows this to drain in a way that's not going to compromise their airway. The lateral recumbent position or recovery position on their left side is a good position to place them in. Of course, assessing stroke patients must also include early recognition of airway threats. For patients who cannot protect their airway and are at risk of aspiration into the lungs, intubating them is the gold standard for making sure that we protect their airway. In your assessment, you should consider epiglottitis if there are symptoms such as sore throat, drooling, or a forward hanging head. Oftentimes we think of epiglottitis as only something that's going to affect a child, under a particular age. But don't let that fool you. Adults can get a form of epiglottitis that can be dangerous as well. So keep an eye out for those signs. All right, let's look at some specific conditions. Dentalgia or a toothache can be the beginning of a dental abscess. Any cavity in or on or near a tooth can harbor bacteria and result in an abscess. These dental abscesses can cause other more serious health issues if unrelated. I have actually heard of stories of an infected tooth or a dental abscess resulting in cardiac issues with patients. So they can affect other parts of the body if left untreated, in part because of the vascularity of these areas of the head. A dental abscess, when that bacteria spreads from the cavity into the gums, facial tissues of the bones, or even in the neck, we start to have some major issues. In some cases, it may need to be drained surgically before anything can happen. And this picture here is a pretty good example of kind of what that looks like from the outside. On the inside, it's going to be just a mess. And they may have to drain that pus in order to get ahead of it with some antibiotics. If the infection becomes systemic, the patient may begin to develop fever, chills, nausea, vomiting, those kinds of things. An abscess in the throat, neck, or under the tongue can make breathing difficult. And of course, remember, our pre-hospital treatment of these is going to be primarily focused on relieving some of the symptoms. If there's drainage in the mouth, have the patient rinse the mouth out with warm water. Ideally, you would recommend that they not swallow that drainage, that they, either spit it out or let it run out. Encourage the patient to be transported to a medical facility for additional treatment. With issues with this oral soft tissue can be the root cause of many other health problems. So gum disease has been long linked to heart disease, stroke, diabetes, osteoporosis, and even low birth weight in babies. So common mouth disorders include things like cold sores, canker sores, oral candidus or thrush, which is a yeast infection, gingivitis, and even bad breath are things that are all linked to those soft tissue diseases or oral diseases. Patients oftentimes may feel too embarrassed to talk about their mouth conditions, so be mindful of that. So when assessing mouth sores or lumps, you might want to rule out urticaria or even allergic reactions that may be the cause. Also realize that more than likely you're not going to be getting a call because of somebody's mouth issues. Sometimes we do. Many of these issues may be secondary issues that we're finding during our assessment. It's important to realize that some of these things could be detrimental to a patient's health, and that's why it's important that we identify those things. Some of these things are not going to be detrimental. Like we talked about styes and all that stuff in the first part of this chapter. It's not really detrimental to their health, but it's important for the paramedic to understand what that is and what the cause of that is and how that's treated. So, oral candidus or thrush, it's a condition that occurs when the candida fungus builds up on the lining of the mouth. Now, this might sound like something that's like, oh my gosh, the candida fungus. Well, the candida fungus is kind of there. It just gets an opportunity to grow and thrive. What we usually see with this is these creamy white lesions that may appear on the tongue or the inner cheeks. It's most commonly seen on the tongue. These lesions can be painful. They may bleed if rubbed or scraped. And the infection can actually spread if untreated. So it can spread to the roof of the mouth, the gums, the tonsils, or pharynx. Thrush is most likely to be found in infants or patients with compromised immune system, maybe even patients that wear dentures. Sometimes we'll find it in patients that use inhaled corticosteroids, and some patients that have been taking really, really strong or long-term antibiotics may develop thrush. It's a relatively easily treated thing, but it's important to be aware of it. So some other symptoms that they may have would be, bleeding and pain, maybe cracking or redness at the corners of the mouth, a loss of taste, and can you imagine that cottony feeling in their mouth with all that junk in there? In more severe cases, the lesions can move down the esophagus, making it feel like food is getting stuck when they swallow. So these patients are at increased risk. The patients that are at increased risk are the ones that have a medical history of things like AIDS, cancer, diabetes, vaginal yeast infections, or anything that would indicate an otherwise compromised immune system. Would be the patients that that definitely need to make sure they get this treated. It should be a priority. Of course, we're going to make them as comfortable as we can and encourage them to follow up with a physician unless they've got some of these comorbidities that might make it a little more serious, or if they've got some other things going on that may otherwise indicate that we need to transport them to the hospital to go ahead and start getting treatment now. This is a little weird one here. This Ludwig angina is a type of cellulitis caused by bacteria from an infected tooth or a mouth injury. The cellulitis occurs on the floor of the mouth under the tongue. You may also see redness and swelling around the neck or under the chin, and the tongue may also be swollen. In severe cases, Ludwig angina is caused by may cause rapid swelling and airway obstruction. So you may need to manage the airway through the nasal passages or via a cricothyrotomy or something along those lines if they start to, begin to have airway management issues. Symptoms typically include a difficulty breathing and swallowing, maybe some neck pain, and even some swelling in the neck. Fever and drooling is pretty common, and altered speech sounds. This is one of those that might make you think that they maybe have a different issue going on, a more serious issue. But doing your homework on these will be really, really helpful in kind of narrowing it down to it being a Ludwig angina instead of something more serious. Of course, aggressive airway management in those severe cases is going to be the primary way that we're going to treat these in the pre-hospital setting. Epiglottitis, on the other hand, is just simply an inflammation of the epiglottis. As you're aware that in severe cases, it can actually swell up so big that it blocks the trachea and obstructs the airway. Some similar symptoms in some ways to Ludwig's, but it is different in the cause and, of course, the area affected. Often caused by the Haemophilus influenza type B. Of course, that virus is typically found in unvaccinated adults. So it can be prevented with the HIB vaccine, and this vaccine is commonly given to children in the U.S. So it's why we don't typically see a lot of this in adults, because most of them have received that vaccine, but sometimes children under a certain age have not. So it kind of explains why we can see that epiglottitis in them, but it's not completely unheard of to find it in an adult. So symptoms that we'll see is fever, sore throat, painful swallowing, stridor, and respiratory distress. You can see that a couple of those symptoms sound very similar to Ludwig's, but remember, Ludwig's is going to have the swelling tongue, the swelling neck, and the puffiness, and those kinds of things. That's going to be a little different from epiglottitis. So other signs that we might see: the patient may appear sick and anxious. They may sit up in that classic tripod position, or even in the sniffing position. We might see some drooling and increased work of breathing, and they may be a little pale and have a little cyanosis, that we're able to see. It's kind of starting to show up. Of course, transport them in the best position possible to maintain the airway. We don't want to spend a whole lot of time on scene. We want to minimize that time. Avoid any procedures that can agitate the patient. And with young patients, this is going to be very, very difficult to do. We don't want to get them crying and get them wound up. We want to try to keep them as calm as possible. Don't even try to attempt to look in the mouth, because the slightest little messing with that epiglottis can make it just swell uncontrollably. Make sure you alert the hospital about your suspected diagnosis and the patient's condition so that they're prepared for that. And of course, you need to be vigilant and be very prepared to manage the airway using alternate routes, such as nasal or via a cric. Swelling and inflammation of the larynx is called laryngitis, and it can often lead to that hoarseness or loss of voice. It can be caused by something as simple as overuse of the voice, and the most common cause is by a virus. But it can also be triggered by some other more common things, such as pneumonia, some irritants, chemicals especially, gastroesophageal reflux disease, bronchitis, allergies, and even bacterial infections can cause this as well. Symptoms can often include fever, hoarseness, and even swollen lymph nodes in the neck. So what we want to do is get a really good history to rule out an evolving upper airway obstruction or an allergic reaction. There may even be a fracture of the hyoid bone, due to some type of trauma. And of course, in less severe cases that you're not going to transport, you need to make sure you advise the patient to follow up with their physician. Tracheitis is a bacterial infection of the trachea caused by the Staphylococcus aureus bacteria. It often occurs in young children following a viral or upper respiratory infection. The infection can become problematic because the trachea can become easily blocked by the swelling, which can result in a life-threatening situation for them. So you're going to have to be prepared to look at those alternative airway management techniques. Symptoms of tracheitis include deep croup-like cough, difficulty breathing, high fever, high-pitched stridor with breathing as well. They may exhibit signs of tripod positioning and may even have some intercostal retractions when they're breathing. Remember, this condition can progress from respiratory distress to respiratory failure pretty quickly if not addressed. When it comes to treatment, our role is primarily that to provide a supportive care. Keep the patient calm as possible and reduce the stress, and try to keep the symptoms of the more severe respiratory symptoms from progressing. 100% oxygen is what we need to give them. Put them on a pulse ox to monitor their oxygen levels. And of course, keep an eye on vital signs. Be ready for a difficult intubation if it resorts to that. And also you need to be prepared to secure an alternate airway if needed. And of course, we're going to transport this patient as quickly as possible because this is a true emergency. Tonsillitis, of course, swelling and inflammation of the tonsils. We have lots and lots of kids that go through this, and lots of adults as well. It's usually caused by a viral infection, but it can also be triggered by a bacterial infection. Symptoms include clearly swollen tonsils, sore throat, difficulty swallowing. They typically present with red and swollen tonsils. They may have a white or a yellow coating or patches on the tonsils, and maybe even fever or a sore throat that kind of goes along with it. They may also have some enlarged or tender lymph nodes, bad breath, headache, stiff neck, maybe even some drooling. The patient will need further medical attention and treatment, so we should transport them for further evaluation. Pharyngitis is an inflammation of the pharynx. These typically don't present with a whole lot of pain or discomfort when swallowing, but it's typically caused by the rapid onset of a sore throat. Seems odd. Pharyngitis usually includes fever. They may have redness in the throat, headache, patches in the throat as well, some congestion, hoarseness, maybe a cough. Treatment will usually require follow-up with the emergency department or their personal physician. One of the biggest concerns with pharyngitis in the pre-hospital setting is the possibility of it developing into a partial airway obstruction, if that swelling gets out of control. A periotonsillar abscess is a collection of infected material around the tonsils. These can go hand in hand with tonsillitis, and it's a complication of tonsillitis caused by a bacterial infection. This condition has become much less common with the use of antibiotics to kind of keep things under control, but it can be very problematic if it gets out of hand. With periotonsillar abscesses, one or both tonsils may be infected, and even the roof of the mouth, neck, or chest may become infected as well. The patient may experience chills, difficulty opening their mouth, pain when opening their mouth, facial swelling, drooling, fever, headache, a muffled voice, sore throat, tender glands in the jaw and throat. So there's a multitude of symptoms, as you can imagine, that may be present. Treatment is going to include antibiotics and possibly even draining the abscesses, which is not something we'll do in the field. In some cases, they may require a tonsillectomy as well. Because of the risk of airway compromise, hospital transport is necessary for further care. You look in their mouth and you see what that picture of these things showed. You're definitely going to want to transport them because the likelihood of an airway compromise is pretty high. So the posterior condyle of the mandible connects the temporal bone, and this unique connection can result in different types of temporal mandibular joint disorders. The cause of these can include, damage to the joint itself due to maybe arthritis, maybe previous or current jaw injuries, and even can be from jaw muscle fatigue from maybe night grinding or clenching of the teeth. What we typically see with these is headache, jaw pain, aching around the ear, or uneven or even a painful bite pattern, difficulty chewing, and the joint may even lock, making it hard to open or close the mouth. The pain and discomfort from TMJ can be managed with pain relievers, typically most over the counter. Sometimes things don't improve and the doctor may recommend surgery to fix the problem. Ultimately, dealing with TMJ in the field is not something that we can deal with or that we can do effectively. Patients will actually need to seek the advice of their doctor or dentist for long-term care of that, but it is very possible that we wind up transporting somebody with that. And with that is the end of chapter 20, and all there is to know about the diseases that affect the eyes, ears, nose, and throat. We'll see you guys back in chapter 21.